Thanks very much, David and Scott and the organizers for having me here. So we're going to be switching gears a little bit from the lectures that we've been hearing about this morning relating to delivery of care to patients and talking on a broader scale in terms of overall quality and improvement of quality for inflammatory bowel disease. With the specific charge that I was given, what should we know and how practically might we think about implementing it into our practice? So why should you care about quality? Well, the idea with quality improvement isn't to set the bar very high. The idea is to set a uniform basic level of care, a low bar that everybody can achieve, that everybody adheres to, that provides a basic care for all patients. Quality improvement science really centers around the avoidance of overuse, underuse, and misuse of various medical interventions. Overuse, for example, doing colonoscopy too frequently. Underuse, perhaps not prescribing those biologic medications when they should have been prescribed already. And misuse, clearly doing the wrong thing at the wrong time. But in addition to providing good care for patients, you should care about quality because it will affect the bottom line. Reimbursement will depend not only on what care is delivered, but also the quality of that care provided. I don't know how many people currently participate in pay-for-performance opportunities, but certainly they're around, and we'll talk a little bit about how IBD is now in a pay-for-performance model, as well as with impending and upcoming and active healthcare reform. Accountable care organizations are going to be holding us financially accountable for the care that we deliver. So what is good quality care for patients with inflammatory bowel disease, and from whose perspective? And that really, the answer to the question really depends on who you're asking. We've been hearing this morning about prescribing appropriate therapy, avoiding steroids, cancer screening, appropriate monitoring on thiopurines, for example. These are things that we do as clinicians. But from a system perspective, we might be thinking more broadly to prevent preventable complications, to reduce hospitalization, surgery, and costs of care. And from a patient standpoint, are we promptly evaluating our sick patients? Are we returning phone calls in a timely fashion? And one of my personal favorites, this is from the British Society's standards of care, is there sufficient bathroom access and toilet paper in clinics where patients with inflammatory bowel disease are being seen? And all of these may be considered markers of good quality care for patients with inflammatory bowel disease, depending on who's asking the question. But we may be held accountable for adhering to these standards. So the objective for today is to review opportunities to improve care in IBD, to highlight variation of care in IBD as an important marker of poor quality of care, to discuss what are quality indicators or quality measures, and specifically how they apply to inflammatory bowel disease, and to discuss a little bit about the future. So first, the good news. Is quality improving in IBD? And Ashwin has already shown us that we've had reduction in surgery, which is arguably an important outcome measure of quality over the last number of decades. And you can see here that the rate of surgery at 5 years has been decreasing for Crohn's disease over the last number of decades. So that's the good news, and that's before the active implementation of any quality improvement programs. However, there are still many opportunities where care does fall short of its therapeutic potential. These include variation in practice, which, as I mentioned, is an important marker of poor quality of care. Inappropriate care, where what we do introduces risk that exceeds benefit. There are preventable complications. Even though most preventable complications we consider are rare, when they occur, they can be devastating. And there's significant waste and high costs. And these have been really well summarized by Brent James, who is one of the fathers of the quality of care movement really over the last number of decades at Intermountain Health. And anyone who's interested in hearing more from him, you can just put him in on YouTube and you can hear some fantastic lectures about quality of care. All of these are true for inflammatory bowel disease, and publishing more review articles and guidelines are unlikely to solve these problems, as has been shown by several studies. So I'd just like to walk through some of these in terms of demonstrating that significant variation in care for IBD does exist, as well as inappropriate care, and how that may actually impact patient outcomes. And again, to highlight, unwarranted variation in care is often evidence of serious and widespread quality problems. So is there variation in care of patients with inflammatory bowel disease? This is one study that we did several years ago addressing the common clinical scenarios among gastroenterologists who are considered to be quote-unquote experts versus community gastroenterologists. How would you manage a certain scenario with respect to the prescription of 5-ASA products? And not that there's a right or wrong answer here, but the key is that there are differences, and experts and community gastroenterologists differed in their prescription of 5-ASAs for each of these 4 clinical scenarios. There's variation in colectomy rates. This variation may be race-dependent, as is shown here by Jeffrey Wen a few years ago, that whites had higher rates of colectomy than blacks or Hispanics. There's geographic variation in colectomy rate. For some reason, in 2003, the Midwest had much higher rates of colectomy than the rest of the country. I wonder if that's due to the practice of some people in this room. But not that there's a right answer, not that everybody has to be the same, but the fact that there's variation indicates that there could be some problems in the quality of care being delivered. Does quality of care or variation in care translate directly to outcomes? This was a study done by Gil Kaplan, where he looked at the surgical outcomes of patients with inflammatory bowel disease based on the volume of colectomy performed at the hospital. And looking at hospitals in the United States, on the red on the left, you can see here that the vast majority of hospitals in the United States, more than 1,400 or so, performed 3 or fewer colectomies annually. On the far right of the slide, you can see there are very few hospitals, less than 100, performing more than 10 colectomies annually, and the green are somewhere in between. And then he looked at the outcomes of colectomies performed at these institutions. And what he found was that the hospital volume was actually associated with mortality for colectomy in patients with ulcerative colitis, such that those hospital volumes with considered to have low volume, the red on the left, actually had more than double the mortality of hospitals that were the reference range, those that were performing high volume colectomies. So you can see here that this variation in care actually translates directly into important patient outcomes such as mortality. Why is there variation? This was an interesting study where we went into details of interviewing practitioners in the Kaiser Permanente, Northern California area. These were 17 gastroenterologists, 1 nurse practitioner, asking them about attitudes and practice of inflammatory bowel disease care. These are some of the themes that emerged from these discussions. IBD is more of an art than a science. IBD is often difficult to protocolize. Often there are several right answers for a given situation, and patient preferences differ, and these patient preferences are obviously taken into account when making management decisions. There's wide variation in phenotype, presentation, and progression of disease, and insufficient educational materials and guidelines, which is kind of interesting. Looking at PubMed, last year there were 12 publications every single day in 2011 in inflammatory bowel disease. But despite that, there's still a perception that there are insufficient overall educational materials and guidelines in order to standardize care. So we see that certainly there's significant variation in care, and perhaps some of the reasons why. In addition, we have preventable complications, and these cartoons at the bottom just to remind us that we've learned over the last number of years about some important preventable complications. Again, these are rare, but when they occur, they can be devastating. Vaccinations for vaccine-preventable illnesses, venous thromboembolic events, which are higher, patients with inflammatory bowel disease have a higher risk for these events, which can again be devastating, and the risk of non-melanoma skin cancer, particularly in patients exposed to thiopurines. And this is just results from a study that we did looking at patients' vaccination histories. What's demonstrated in the blue bars for 5 different vaccine-preventable illnesses are the patients at risk for these particular vaccine-preventable illnesses, and in red, what you can see is those patients that actually received the vaccine that they should have received. Again, a significant discrepancy demonstrating that we are not achieving what we should be achieving with respect to our ability to prevent preventable complications. And finally, there is lots of waste and high costs that occur in the treatment of patients with inflammatory bowel disease. So why might our care fall short? Why is it that IBD why don't we achieve our full potential with respect to the issues that were just raised? So as Brent James mentions, we rely as physicians, particularly with a complex disease like inflammatory bowel disease, on the craft of medicine. Clinicians are considered the standalone experts, able to synthesize all of the information that's swirling around a patient and help them make that management decision. But with that comes clinical uncertainty because there is a lack of valid clinical knowledge that can apply to address the specific question for the specific patient sitting in front of me. There's exponentially increasing new medical knowledge, and trying to incorporate that, just keeping up with the literature, is a very challenging task. We rely as clinicians and physicians on subjective recall and experience. Our last 10 patients may dictate more for what's going to happen to our next patient than what we have achieved in a lifetime of experience. And there are limitations of the mind for complex decisions. This is well known in neuroscience and neurobehavioral studies, that our minds can only grasp so many different variables when making a decision, and yet with inflammatory bowel disease, certainly there are many, many variables that need to be considered when considering management decisions. And finally, our care might fall short because our payment model encourages utilization. Right now, we get paid more to do more. That's changing, but certainly it's part of the landscape at the moment. So how much room is there for improvement in IBD care? Well, based on significant variation in care and poor uptake of recommended preventive care, there appears to be significant room for quality improvement. However, before you can improve quality, you have to define it because you have to be able to measure it. So when we talk about measuring quality, we start with the floor. Again, we start with a basic standard of care that can apply to everybody. So we want to build the floor to create basic quality care for IBD, a foundation upon which we can then build a nice house. So what are quality indicators or quality measures? These are retrospectively measurable elements of practice performance for which there is evidence or consensus that can be used to assess the quality of care provided and then change it. There's a Donabedian framework for how we think about quality measures or quality indicators, and they typically fall into one of three categories. We have what are called structure measures, which is the setting in which care is delivered, who is delivering the care, where is the care being delivered, how big is the hospital, how many beds do you have for a specific patient population, do you have an electronic medical record? These are all structure measures. Very difficult to change. Then there are process measures, which are evidence-based practice. That's what we do as clinicians. We do processes, and process measures are the most common kinds of quality improvement measures because they directly affect how we interact and behave in seeing and directing patient care. But arguably the most important quality measures are outcome measures, which is what happens to patients as a result of care that they receive. Outcome measures, though, can take a long time and can be very expensive to be able to determine. So when we think about quality measures for inflammatory bowel disease, we want to put them in a framework. This is the framework or conceptual model for how we think about quality improvement in inflammatory bowel disease. That these quality indicators that I'm going to talk about will be fitting into all of these categories in some way. Assessment of disease activity or quality of life. Diagnosis, we want to be able to diagnose patients accurately and timely and identify and recognize complications. We want to be able to educate patients about what they should and shouldn't be doing, to be able to share decision-making with them and communicate risk effectively. We want to be able to prevent disease complications. We want to prevent overuse of corticosteroids, medication complications. We want to prevent hospitalizations, length of stay, lost days from work and school, and certainly prevent cancer and prevent mortality. And surely we want to be able to treat the disease complications. So what efforts are underway to improve quality care in IBD in the United States? There are three efforts I'm going to speak about. Improve care now. I'll touch upon our efforts at the CCFA and then the American Gastroenterology Association. So Improve Care Now is a consortium of pediatric IBD centers. I think there was one pediatric IBD practitioner in the audience. But this is an incredible consortium that has been growing over the last 5 years or so, which now involves more than 36 centers, both in the United States and actually there's one in the UK as well. And this consortium, they meet on a monthly basis with telephone conferences. They meet in person on a regular basis to really go over outcomes at each of these centers. And the centers that have better outcomes teach the other centers, and they talk about what they did to improve their particular outcomes. Every center, every physician gets updated reports on a weekly basis so that they can see how they're doing with respect to their colleagues and with respect to the other centers, and ultimately learn from each other in this quality improvement collaborative. The AGA has put in a significant amount of resources over the last couple of years to develop quality measures as well for adult patients with inflammatory bowel disease. These began with the development of measures in October 2009, and in January 2012, they went live, so to speak. These are measures that have been endorsed by the National Quality Forum and by CMS as being eligible for Physician Quality Reporting System, or PQRS, which are directly tied to incentives for patients in the Medicare system. These are the AGA IBD quality indicator measures. Document disease activity and severity. Recommend steroid-sparing therapy after patients have been on steroids for 60 days. Assess bone health if steroid exposed. Recommend influenza and pneumococcal vaccine. Document recommendation for cessation of smoking in patients with Crohn's disease. An assessment for hepatitis B and tuberculosis before starting an anti-TNF. These are available on the AGA website. There's a large document supporting the body of literature that may go to support these IBD measures. But these are actually live and can be reported beginning in 2012 for part of the PQRS system. I've listed some of the requirements that you need for that. Currently, there's a 0.5% bonus for those who achieve reporting of these measures in the right way. That bonus is expected to turn into up to a 10% penalty over the next 7 years for those who don't report on these measures. The AGA Digestive Health Outcomes Registry has been established by the AGA to help facilitate gastroenterologists' reporting of these measures. They're linking up with multiple different EMRs. They're trying to enroll providers and create agreements with third-party payers. But the idea behind the AGA is really to support gastroenterologists to help comply with these reporting requirements. Along with the AGA, the CCFA has been undergoing efforts as well. We've had a separate but parallel process with the AGA, perhaps with slightly different goals. The AGA goals for accountability to help with physician incentive and reimbursement. The CCFA's goals have primarily been, generally speaking, to improve quality of care. And what do we need to do to identify and improve quality care? So we started by going through every guideline that's been written in the last 10 years. We pulled out 500 potential quality measures and basically narrowed that down through an extensive literature search and meetings with expert panels and physician groups to a final list of top 10. And interestingly, our top 10 process measures were very similar to the AGA's process measure set with a few differences. These are highlighted here in addition to what the AGA measure set included. The CCFA's measure set includes testing for C. difficile and flares, FlexSig for CMV and steroid refractory hospitalized ulcerative colitis, checking TPMT before starting thiopurines, and recommending colectomy or close surveillance for low-grade dysplasia in patients with colitis. But in addition to process measures, we've also come out with an outcome measure set. These are important outcomes that can and should be tracked and followed as a measure of success of quality improvement. Steroid-free clinical remission, days lost from school and work, days in the hospital per year, is a patient having surgery, incontinence, nighttime bowel movements or leakage, ER visits, anemia, and malnutrition as things that can be determined as important outcomes that could be, again, indicators of success for quality improvement. By the way, in establishing these measures, we had multidisciplinary groups which included physicians and nurses and patients themselves. This is our CCFA QI team. I just want to mention a couple people, Tom Ullman and Corey Siegel from the Professional Educational Committee at the CCFA. I want to mention Russ Cohen, who's our liaison as a guidelines editor at the IBD Journal, where the CCFA measures will be published, and Dave Rubin, who really began this process several years ago with planting the seeds and developing them for quality improvement at the CCFA. So in summary, what should we know? Variability in IBD care is significant, and we need to avoid preventable complications. Hence, the idea for quality indicators that could provide, at least tell us what is the basic quality that should be provided for all patients. We have 2 current sets for adult IBD care, the AGA measure set for accountability, which is available on the AGA website, CCFA process and outcome measures for improvement, which were presented in abstract form and will be published in the IBD journal. And how do we implement it in our practice? They can be implemented manually via EMR, via using checklists, and the AGA Digestive Health Outcomes Registry. But measuring quality is just the first step. We have to measure it, and once we measure it, then we got to work on improving it. So we've built the foundation. As I learned yesterday, the Sears Tower Foundation took over a year to build with 1,500 people. We're getting there, building the foundation. Hopefully we'll have a nice quality house for us all to live in. Thank you.